Good evening, everyone. I would like to welcome you to this second session of ROP. It's going to be an interactive panel discussion, and we have eminent speakers from all over the world. And without further ado, I'm going to invite Dr. Hassan. So this is going to be either a case or a video-based presentation. So Dr. Hassan is a consultant veterinary surgeon at Dubai Hospital. So
Thank you, Dr. Rao, for the moderate this session, and thank Dr. Amri for the invitation. Just let me share my presentation. Our present today is vitreous. Can you see the slides? Yeah.
Yes, I can see it.
Yeah. About neonatal vitreous hemorrhage. During our screening for the NICOs in DHA, we faced this situation. So I want just to bring this topic here because maybe this is for us more common than retinal detachment or anything else. This baby is just I will give brief history about the baby. Full-term baby, cesarean section. The baby has tubation post-delivery directly. MRI, there is intracranial hemorrhage, intraaxial and extraaxial, and the baby has thrombocytopenia, abnormal coagulation profile. And through the fundus examination, he has a right eye multi-layer retinal hemorrhage, sparing the fovea, and the left eye there is in Berger space hemorrhage and very dense vitreous hemorrhage. And we observed the baby for 1 month. Then we decide for the surgery after 1 month because the baby was underwent for shunt for the hydrocephalus. And this is the surgery. You can see here is how is the concentration of the hemorrhage in the Berger space. We should remove it, and especially here the lens is a globus, so we should take care during removing this hemorrhage, and very dense organized hemorrhage. And even here is maybe not like adult, you can't do the BVD as we think. You can see here the vitreous hemorrhage layers and the vitreous face is there in the back. And removing the vitreous face from the macula, there was retinal fold, and there's a peripheral membrane. Try to remove it by the MaxiGrip forceps, and there you can see it's opened. And as there is huge remnant of vitreous face on the back, and the baby just is, to avoid any traction on this area, I color the ILM to be sure that it's removed. It was removed the peripheral membrane, and just I extended here, and you can see it's very delicate and very elastic membrane, as in the anterior capsule for cataract and these kind of babies. Just I want to give before discuss this case that retinal hemorrhage is very common for us in the NICOs, and it's multi-layers, generally extensive rough spot. Here we go for further investigations, and it was diagnosed was Terson syndrome, and there is differential diagnosis. We should go on with this, and the most important thing here, just if we will go for MRI for the baby, to go for the orbit and request it to evaluate the optic nerve. Multidisciplinary team here is very important, pediatric, neurologist, hematologist. It will extend at least our situation with the reason, especially if this is not ocular reason like congenital or anything, if it was systemic especially. At the time of the surgery, this is a debate, and I hope that all of the experts in this meeting, this session, will help us about their experience about when the time. Most of the literature, they said after 1 month, mostly if delay, it could cause the patient myopic or pigmented retinopathy. A spontaneous resolution, it's happened even within 2 months or 3 months, even in sub-ILM hemorrhage. Here I finish my poor prognosis. This is about the poor. In our patients, there wasn't a huge improvement in the vision. Because the baby from the beginning is around the same, according to our evaluation. So he has clear evidence of neurologic lesion. So I don't know if anyone, panelists, have any comments on this, or if anyone have any other opinion.
Well, Dr. Hassan, I have some experience of seeing these kind of babies and operating on them. You see, the problem here is one could be at times like we have those battered baby kind of syndrome, those kind of situation we will never know, because you rightly said that they do very poorly. They're usually, we find that they have a neurological problem and the optic atrophy would be there, and visually and otherwise also neurologically, we send them to pediatric neurologists. They have multiple issues. So you are absolutely right. So that these babies, we do not know why. We do, as I said, one possibility is battered baby, because that is what can lead to multiple issues in neurological as well as in the eye, and they don't do that.
Generally, we
Can I
observe
add?
this.
Yeah.
Yeah. Observation when you decide for the surgery in these cases. For
Yes,
like
early
vitreous hemorrhage.
surgery, we have to do early surgery. Early in the sense, I think we might wait around what you said, a month, because these are both eyes are involved. It's not really urgency that you go, and they may have a lot of systemic issues also. So we need to have a neonatologist or a pediatric neurologist also on the board.
Yeah, I just
Dr.
wanted to
Shubham.
add two things that, in we have published also, maybe somebody can look up that publication on neonatal vitreous hemorrhages. In our series, we had cases of a very rarely battered baby, because mostly they are on the ventilator, as you showed, they are in the hospital only. So it's very unlikely that they had a battered baby unless the nurse was battering. But we do see them due to birth trauma. But the other important thing is we do see a lot of these cases following torch infections, especially CMV retinitis and viral retinitis. And you can see those heel scars. As soon as you remove the hemorrhage, you can see. The important thing post-operative is the visual rehabilitation. They can have a field which is still functioning. They could have a quadrantenopia, they can have hemianopia. So many people don't test their fields and they don't test which side the child is seeing. So we now have a pediatric perimeter which checks it, but even before that, in our visual rehabilitation department, all these babies, they would check them every 2 weeks, 3 weeks, and see from where they are perceiving the light, which side they are seeing more, and then they would give them visual stimulation from that side. And doing that, even if they have had shunt, even if they have had CNS hemorrhages, some of them take time, but they start seeing. Usually it takes 2 to 3 years for us to know what is the final visual potentials. And of course, they all get myopia. Once we do vitrectomy, they will get myopia very rapidly. Within 2 to 3 months, they will get -8 to -14 myopia whenever we do vitrectomy in newborns. So I think these two things get missed. And if it was in one eye, then we definitely start patching 2 hours per day. So I think the post-operative care is something that is missed, and then they just go down the line. I think that should be given importance to get the maximum potential out of our surgery. It is possible that they may not see ultimately, but I think we should make all attempts to give them the best visual, rehabilitation environment. We do that for all our stage 5 ROPs. We do it for every surgery that all the newborns who undergo surgery, vitreoretinal surgery, they immediately 1 week post-op, they have appointment with the rehab team and with me. And then at 4 weeks, then 3 months.
It could be the CBR. It could be sometimes cause these kind, because according to literature,
yes, CPR also causes it. Yes.
But according to literature, that the CBR for us, maybe we saw a lot of babies, and this is maybe one of the rare cases. But the CBR something is common. So generally, according to the reports, the CBR, they said in the posterior bole, this is something that didn't happen regularly for the babies. I don't know for me why, because this case came as to see everything, that the CBR, even through your experience, Dr. Susanna, Dr. Monget, Dr. Subhadra, didn't cause this kind of extensive hemorrhages intracranial.
Well, in my experience, I never had such a case.
Dr. Susanna,
So,
yes? Can we have a discussion in the end? Because usually what happens is we'll end up with just last few speakers not having.
Okay.
I think Dr. Prasan lost connection. So Dr. Magdata is came back.
Yeah.
He came back. Okay.
Yes, I think I'll share my screen if you can stop that. Thank you. You can see my slide here. Okay. Is it visible, Susanna?
Yes, I can see it perfectly.
Yeah. Okay. So I'm just going to talk about something which I've been very, very passionate about, the nasal lens sparing vitrectomy a little bit. The idea here is that we want to spare lens at every cost. I think the reason is that the lens is so important, and we have to sacrifice the lens in many situations. And so the main advantage of phakic is, you see, the visual rehabilitation, which just now we were talking. And also, once the lensectomy is done, then there is a ocular hypertension, glaucoma, as well as amblyopia as a problem. So a lot of issues. And I think we do have evidence that in 4B, in this series, almost 57% required lensectomy. And so I think we all know that, because there's a huge temporally the retinal detachment coming almost close to the lens, and we can't achieve the objectives. So with that idea, this is the case. I'm going to present to you the left eye progress to stage 4B. In fact, by the time we took up for surgery, it looked like that. And so what was done here is all nasal, that you put the infusion in the center here, sit on the nasal side, and put in the center. And for the cutter and the endominator, you are on the other side. So that is what I'm going to show to you. And so this is the case where you can see we want to spare the lens. The retina is almost coming behind temporally. So it's no way that without sacrificing lens, we can go any other way. So thought of going nasally, and in the center, you put infusion cannula. And this is rather advantage. It because of the nasal bridge, it remains up, it doesn't touch the lens. It is rather much better than what we do, and we keep on putting that up at other places. And we also so in this particular case, you can see the infusion is in the center, and now these two ports are made on either side. So with the cutter, and this is the endo illuminator you have gone, and you are sitting on the nasal side. Now, this particular case, if you look at it, it's fairly advanced now, and you can see on intraoperative OCT, the retina is going up all the way. And so as we all do, I think we are all doing these surgeries. I think we have to remove as much vitreous as possible everywhere. And then you just go to the areas which you can sort of safely cut all those adhesions or those fibrotic elements. And the problem here happens that we don't have to be going overboard, because if we create a break in that particular area, then nothing can be done, because the retina here is already fibrotic, and you can see that. And so after I could see here that there's a large vessel. So here the cautery was done, and after cauterization, one could, you see, go again and cut this very easily. And once this was done, and that was almost the end of surgery. So you don't want to really do too much. As you will see here, now the retina is fallen back. You can see on the intraoperative OCT, now it is not up, and you can see it, how it looks like at this stage. And so that is almost the end. And after this, you just do a little partial, we all do, exchange. And I tend to suture in some of these cases, so, because it may bleed, otherwise that's the problem. So that's how, and in this particular case, as you will see, did very well. And in fact, we could spare the lens, and you can see the retina going back. And this is at 3 months. So I think we did publish this. This is in ophthalmology. This is in retina. So this we have done a number of cases. And this is ideal for stage 4B with extensive temporal TRD. Some of my friends have done. Susanna, I want you to try, and other people to try this one. Some of them, they've been very happy, and they could spare the lens, and all objective could be achieved. So thank you very much. I just wanted to kind of highlight this procedure, which might be of great benefit to us. So not that it has not been very well described. Of course, we all know we keep on shifting from one place to another as far as, yes.
Very interesting, Dr. Mangat. This placement of the sclerotomies on the nasal side, I think especially as you said, when you have a temporal issue, approaching it from the nasal side really makes a lot of sense, and especially trying to save the lens. Yeah, Dr. Sudhana, you're trying to say something.
It was a magnificent work, and I liked the time frame between the last observation and the inside OR observation. So it's a dynamic thing. You plan a surgery, and then when you go to the OR, it's completely different. So you must shift and see where you can put the trocars and all that without touching the retina. And usually we go on the nasal side because the temporal side is occupied with the retina. So very nice video. And really, it's a technique that I also use. And it's a wonderful to see it published, by you, and to enhance this kind of technique. Yes, it's very important. It's very important because people is attached with these adult positions and forget that we can shift the baby wherever you can, because it's a little baby. You can make the surgery in the same place you have, and then just turn the baby and go nasal, for instance. So yes, thank you very much. It's a wonderful presentation.
Thank you.
Well, I didn't brought a video because I thought everybody is going to bring videos. So I thought, no, I'm not going to bring a video, so I cannot. I didn't bring any video because of surgeries, because you are such a wonderful surgeons, that I think I would bring something else that sometimes make me a very hard time, that it's the cases that send me that seems like ROP, but then suddenly they are not ROP. So they give us some kind of trouble to make the diagnosis and to make the treatment. So this baby was referred to my hospital, telling he had a stage 3 type 1 ROP. It had to be absolutely treated because it was a rush disease. So I look at it, and as you can see, it does not seem really ROP. It's less, that doesn't have plus disease, but has that abnormal vessels, really. And you have stop of the progression of the vessels. You have some kind of ischemia posterior in to the vessels in the right eye. So this is the right eye. And then the left eye, you have this abnormal under the retina something, and the vessels, they come to the vitreous. They are like, you can see in different plans. So you can see, you have the vitreous inside the middle of the vitreous, those vessels, as you can see here in this angiogram. So I decided this was not an ROP. It's, of course, we needed genetics, but I would not make a treatment like this with anti-VEGF, because in my experience, it will contract and make a lot of fibrosis. So I think this is a mixed, it's more a fever than really an ROP. So in these cases, I'm very careful, and I like most to do laser than to inject anti-VEGF. So I did it and explained my colleague it was not, although the baby was premature, it was not an ROP. And then I decided to do laser. And the situation is stable. The baby is now 4 years old and the situation is stable. So we must be careful when they send you referrals with the name of ROP, then suddenly they are not ROP. And if you don't diagnose it, you can have a problem of not, the treatment will not be a good treatment with anti-VEGF. And you can see here, you have ghost vessels in the eye, and the situation is quite calm. And I keep receiving babies like this. So this is second baby that came to me, and they referred to me, and they wanted me to see this ROP. but it was not an ROP because it was a 37 weeks age, postmenstrual age. I just have the late times of this baby because it was a difficult, the first times I missed the first times of the floor scene. But as you can see, it's a very big baby with what it seems an ROP. I didn't treat it right away as it was a big baby, but with this stop of vascularization and what it seems a stage 2, and allow him to have a month. And a month later, he had like proliferation, but just like ghost vessels. So it was a white proliferation, almost like in incontinentia pigmenti. I'm used to see this sometimes in incontinentia pigmenti, and there was no progression of the vascularization of the retina. This time I took care, and we had all the times in the floor scene. And if you didn't know it was a full-term baby, you could say it was an ROP. But really, it's a full-time baby, and you can have this proliferation in the periphery, and those vessels, cutted vessels, very like also the fever. You can see in the periphery of the right eye, in the periphery of the left eye, the vessels are cut, and they have impregnation and a little bit of diffusion. So I decided also to make laser, not inject anti-VEGF, but make laser. So this is a kind of mixed between fever. This is, I think, a fever, although I don't have the genetics of those babies. Finally, I show you my nightmare. It almost make me lose my faith on anti-VEGF. It was not a very little baby, but has some kind of an aggressive posterior ROP, and it behaved not normally. What I mean, it's the only baby I had to inject twice. So I injected once, it has a relapse disease 3 months later, injected twice, and 3 months later again, he had another relapse disease. I did laser, and after the vitrectomy, there was a whole contraction of the retina to the optic disc. So this is an abnormal ROP, as I can say. It seemed almost like an oxygen-induced retinopathy, but he has no problems with oxygen at the time, and he behaved like what we now call our ROP babies, mixed between ROP and fever. So I bring this just to remember that there are a typical ROP that we must diagnose. We still don't know what's the best way to treat those babies, but we must and try to understand which baby is a real ROP and which one has this behavior as a fever or as ROP or as oxygen-induced retinopathy, because they have all different treatments. So must always have in mind this diagnosis, differential diagnosis for ROP. So that's my presentation. It was just to enlighten something different, and that give us a lot of trouble and have long-term treatment. We must never stop looking, at least for fever, and sometimes for this this fever-like ROP babies. They have very long periods of quiet eyes, and suddenly we have recrudescence of the disease with a lot of fibrosis. So we must never lose control of those babies. So that's my presentation.
Great, absolutely fabulous, very nice.
Dr. Subhadra, can I ask you, for the sake of the audience, what are the ways we can differentiate between fever and ROP? Are there any clues and tips and tricks?
I think Susan showed very nicely. I'll just reiterate. One, in FEVR, almost always the pupil will dilate very easily as compared to ROP. In ROP, they have NVI and the pupil takes time to dilate, and the more severe the ROP is, the more time it will take to dilate. Even stage 1 ROP, it takes more time. The second very important thing is that if you are following a baby, suppose like this baby, you saw a ridge. If you follow an ROP, the ridge will move. It will always move. The disease will change. Either it will worsen or it will improve, but the ridge, where the ridge is, it always moves. Whereas in FEVR, it is arrested vascularization. It always stops there. If you saw the first visit, the second visit, the third visit, every time the ridge will be exactly where it was before, and mostly it is in zone 2 or sometimes in zone 1. The disease may progress, so the proliferation may increase or it may remain arrested for a long time. But the point where the vascularization stopped, it stopped. It will never vascularize the avascular retina. Whereas in ROP, always the avascular retina starts getting vascularized. There may be few twigs, it may vascularize slowly or faster. So this is another thing. And of course, the parents' examination, we have found at least 30% of parents have a sign of ROP, so of FEVR. So I think the siblings and the parents, if you examine, they may come with squint, they may come with anisometropia, they may have had retina surgery, they may or may not have been diagnosed to have FEVR, they may be asymptomatic, but always dilate the parents and examine their retina, and that may give you a clue, especially where you're not getting the genetics. And of course, the FFA characteristics already we saw, it seems as if the vessels have been cut. And the posterior pole is again important in most of the FEVR cases, although we do have a fulminant variety, but in most of the FEVR cases, you will not see any plus. So plus is quite unusual. We do have a fulminant type, which resembles the APROP, but new vessels in the zone 2 without plus, when you see there's absolutely no tortuous dilatation, then you start thinking this is FEVR or ROP.
Great.
Okay. Anyone wants to add anything?
Good, great, absolutely.
So, yeah.
Subhadra has
Very
a lot of
nice.
experience with fever.
Yeah. So next I would like to invite Dr. Tapas Ranjan Padi. He's a consultant VR surgeon and ROP specialist at LV Prasad Eye Institute. So Tapas, the floor is yours.
Yeah. So good evening. I'm sorry, I have some issues with the video. But let me share and take you through a few interesting findings here. So the interesting pre-retinal that candle wax like deposits. You can say it as mat-like deposits also in ROP. And that few cases, how they have behaved, that I am going to share with you all. Case 1, quickly, 30-weeker baby, birth weight 1500 gram, unblended oxygen for 1 month. Most of these babies I'm going to describe they hail from 1 or 2 specific NICUs where the oxygen handling is not per standard. So baby was sick, so we had to inject. And within 1 to 2 weeks, these deposits melted dramatically. And till last follow-up, the vascularization was up to zone 3 without any recurrence. Now, case 2, here, if you look at it, there is a sheet of this pre-retinal candle wax like deposit. You can see here, they go all around up to here. Maybe you can say that 10 clock hours. And if you look at the deposit, there was no blood vessel within it. It is just as if there is a plaster on it. Same thing in the left eye. And at the posterior margin, you can see they look creamy. And again, we injected, and this is 42 weeks post-menstrual age, and they have just disappeared. Like if you put in a frying pan, if you put some cheese, how it melts down, it melted. Case 3, this is more or less like staged ROP, where we see that the extraretinal fibrovascular proliferation. Here the deposits are mixed with few of the blood vessels, and this is the classical approach for this case is for us is laser. But again, as the baby was sick, we couldn't do laser, we have to inject, and you can see the blood vessels, the deposits melted, and blood vessels now has gone beyond zone 2. Look at the left eye. There is something sharply demarcated patch of RP atrophy I was describing yesterday. And this, not only with this, I have seen in a series of cases this patch of RP atrophy has appears post-Avastin, even without anything, and in some cases of post-resolution of retinal detachment. Suppose we have a stage 4A here, and which extends up to this. If it settles down, that leaves behind multiple small depigmented atrophic patch. But of course, it is more common with post-Avastin, and this is my probably 8th case that I have seen this on the series. Now look at this here, the blood vessels, the candle wax-like deposits have some blood vessels. They look a little bit of pink, and also in the left eye. Here I would be a bit hesitant to give Avastin. I kept myself prepared for an injection, laser, and surgery. So he gave injection and look at 2 months post-op, they have gone, vanished. And what to do? When I followed them, he was doing well, and there was no return of the disease activity, so managed conservatively. This is the right eye. There was a broad sheet of pre-retinal deposits here. And the left eye, they were deposited here and there. It was not in the form of sheet like it is if you turn off a pillow and if you put it here and there, it was that way. And again, post injection, they disappeared. But there was an issue with the follow-up, so I lasered. This is the post laser, you can't see, and there was no post injection, post laser, no more these deposits. This baby, if you look, there are again extensive these pre-retinal yellow deposits. They are on the surface of the blood vessels again, and here they go around 360 degree, injected, and the baby was due for a follow-up, but somehow the child was lost to follow-up. When I was following up, the baby called up, the parents informed me that they have gone to another retina specialist who has seen the eye and said that there is no disease at all. Who gave you injection? Why did you take the injection? And so I said him, okay, I have your initial pictures. So this injection works dramatically in these cases. And if a person not aware of this entity will think that as if I have overtreated this. So again, another one, you see that here what is happening, there is something getting dragged up over the disc. The deposits are from here to here, but the retina a bit pulled. So here again, I kept myself prepared for surgery, injection, laser, and surgery. Gave injection, followed by laser, but surgery was not required. I don't know how. In not only the deposits, but the retina flattened out. You can see there is no tint of any fibrosis or anything. While I share all these things, it is important that we distinguish this these candle wax-like deposits from that so-called FBP with predominance of candle wax deposit, again versus fibrovascular proliferation with prominence of the vascular component. While in the first one, Avastin, as we saw with Avastin, they do very well. The last one sometimes can be scary, and sometimes the retina can close together and cause a crunch phenomenon. One should be remain prepared for surgery if he has to inject. And the middle one, like where you have predominance of candle wax deposits, there one should take a middle approach. So the questions to answer, candle wax-like deposits away from the ridge, what do they represent? Do they represent exudate or blood or both? Or are they extensive popcorns? Are they related to oxygen or systemic associations? Why do they respond dramatically to anti-VEGF? We know that post-laser also they disappear, but with anti-VEGF they disappear like anything. So till now, what I have observed to my little observation, lesser the postmenstrual age, more avascular the deposits, lesser the retinal traction, higher the chance of complete resolution of these deposits with anti-VEGF. I thank you all and can take any questions or your thoughts on this.
Absolutely a great presentation and cases. These are the cases you see. If you look at the picture in hybrid ROP, One of the picture published in British Journal is, I have called it mat-like proliferation over the vessels. So exactly, and in fact, even they would melt with laser most of the time. But what it was, I'm still at a loss whether it is some kind of a candle wax which is exaggerated. I don't know, but they are different. And because mostly how you have shown such nice presentation of all cases documented well, here the vessel would always be seen going beyond this. This is as if something is stuck over the vessel. That is the way it is. So this is a phenomena. I think I must congratulate you for collecting such wonderful sort of cases with good documentation and dramatic treatment with anti-VEGF. So absolutely.
Can I give one just one comment, Dr. Thank you for sharing this, Dr. Tabas. But also for us, we found these kind of findings in babies, which especially in the nasal side, as you mentioned, even for us, it's like we diagnose, we follow up by RETCAM. It's like it was extensive for us. Popcorn, as you said, it could be popcorn, and it's already there is this popcorn not just away from the ridge. No, it's around the ridge, and you can see it tracked ridge. They said this is like the stage 3, and it could, if we wait, sometimes go for the fibrosis. And when we inject, as you said, in the nasal side, especially if we found it in the nasal side, it was for us when we see this kind of, we consider it as a stage 3, and we inject to avoid any traction. We have around 3 cases, as you said, that in the nasal side there is the ridges. It looked like that a lot of fibrosis there or whitish material, but I think it's more near from my vision. It's for popcorn.
Okay. Thank
Dr.
you.
Tapas, any
yeah.
Dr. Tapas, did you do an angio for these babies?
Yeah, that is what was our limitation, and maybe next time when I come, I'll come back with the angio, and I'm going to get a machine with angio, and I will get that. I get back to you on.
And if you can do OCT, it will be also very interesting, because in some very sick babies with a lot of stage 3 ROP, you can see white dots in the vitreous. So there may be an inflammation in the vitreous. It will be interesting to compare the vitreous of that baby that has that white stuff and those that don't have that white stuff.
Yeah, yeah.
If you have an OCT, I think you should do it.
Yeah, okay. Okay, points well taken. And let us all document this, and I think some maybe after a few months.
Be a good prognostic marker.
But it has no vessels. It's completely like a pars planitis. You know, if you see a pars planitis, that's the way it seems like. And even when you do laser, sometimes I've got that in the avascular retina. So you do through a little, as I say, pars planitis, that's the way it looks to me. So it may be inflammatory, it may be a precursor for PVR, for neovascularization. But as the vitreous of the baby is so attached to the retina, it's like pars plana, you know, so you do like a pars planitis in there. But I think we all see this, but we never realize what it is. I know that I had a baby with a crown. You know, you have this 360 degrees. It was like a crown on the eye, and I missed the baby. And then he came to me months later with a fibrosis, a terrible fibrosis. So I don't know if it's more fibrosis than, but somehow has no vessels, and seems like, to me, seems like what I call the pars planitis phenomenon, and you call the wax phenomenon. So it's very, very interesting and not described, I think.
It's published. Next, can I ask Dr. Subhadra Jalavi to start presenting? So Dr. Subhadra needs no introduction. She is a consultant ophthalmologist at LV Prasad Eye Institute. And Dr. Subhadra, please start sharing your screen, please.
Thank you. And we'll just go ahead with what Tapas told us, like a candle wax stripping. And I wish I was as lucky as Tapas to get all the cases doing well. So here I have a candle wax type, which develops severe ischemia. So Tapas, I'm trying to follow you, give the injection, but it doesn't work in my hands. So here we have a baby who came to us about 40 days of life, which is late for us. And you can see here all this candle wax dripping like thing came at 7 p.m. when I'm just ready to go home. And then I said, okay, what should we do? Anyway, this baby will need anti-VEGF because it's so bad. So let us inject right away. As the baby came to OPD, we just injected and we said, come tomorrow around 10 o'clock and we'll do the laser, because that time we were not doing monotherapy. So we injected, and then you see the next day my fellow started doing laser and said, I can't do the laser. It's not taking the spots. I said, like, you're not doing a good job. Why it's not taking laser? And when I saw it, to my horror, you can see the baby had these large globules of choroidal infarcts. The whole thing looked white. And I was like, is this infection? Is this choroidal ischemia? The patient had Descemet's folds. The eye was totally hypotonic. This was the first time this had occurred. This is 16 hours after the injection, exudative RD. And if you don't believe it, it's here on the ultrasound. There was total RD, complete choroidal thickening, and it seemed as if it's a shutdown. I didn't know what to do. The only thing I had in my hand was betamethasone those days. So I started 2-hourly betamethasone along with the mediatric because I was concerned that it may develop posterior synecdoche. And so I have heard about anti-segment ischemia after laser, but I had not heard about this type of thing after anti-VEGF. And this is 96 hours later. You can see that the whole plaster thing was going away. There was some crunch here. And this is what, was worrying me, because it seemed that there's a hole there. Now, whether it's a retinal hole or it's a RPE defect with a choroidal rupture, I didn't know because I didn't have OCT there, but definitely this was something which I was not happy with. But anyway, we just followed the baby. And then in 10 days, you can see the whole thing melted away. The ROP went away, the B scan, the choroidal detachment away. The baby is still on 2-hourly steroids and anti-VEGF. And then I, just followed. And within next 2 weeks, the disease started regressing back. And you can see these subtle recurrences. These recurrences, we have to be very careful. After anti-VEGF, the moment recurrence starts, it's not that always the vessels will start dilating. You can just get these very subtle lesions in both the eyes. It happened. We treated with laser. And you can see because the retina had reattached, it left these yellow deposits, just like you see Dehlen-Fuchs nodules, or after any reattached exudative detachment, all those deposits were there. It looked very scary, but you can see the vessels were fine. Everything was good. And I followed the baby for 2-3 months. She was doing okay. And then I said, you can come after 3 months. So when the baby came 6 months post-injection, the right eye was stage 5. This eye, which you see so beautiful here, well lasered, disease has gone, everything is gone, that even that whole leg thing had got plugged with vitreous. This eye went into stage 5. The left eye, 10 years, is doing well. So really, this was a learning lesson that they can get problems, and it is not only this eye. So what I want to close by saying is that there are choroidal effects of VEGF. The choroid needs VEGF to grow, and these babies can get, problems with anti-VEGF. And I think we need to have more tools to study the choroid in ROP. We've not studied it much, whether with the, enhanced depth OCT or ICG. We know that with electrophysiology that they do have photoreceptor dysfunction, even if they don't have ROP. So the choroidal effects of anti-VEGF, we don't know. If you look for them, you will find them. And this patient, I had this picture in my kitty. I never knew that there was a choroidal rupture till I read this report from Thailand, which said that you can have it. And this is now published. And then we had another few cases where we have given anti-VEGF. You can see these tiny, tiny ruptures. So there's something happening in choroid which we don't know, and we should be aware that choroidal disease can happen. Tapas also showed an RP atrophy patch with anti-VEGF. Even some patients with laser I have seen, but mostly with anti-VEGF. So thank you so much. I think we need to study the choroid more in these patients.
Well, wonderful presentation. It's a nightmare. I never imagined to face such a nightmare. About choroids, yesterday I presented 2 choroids, patchy fillings, but in anti-VEGF injected and in regressed, spontaneous regression. So even ROP will have this effect, not just anti-VEGF. Perhaps anti-VEGF can enhance this disability of the choroid, you know, but it was really a storm.
So what I wanted to, I took this case because of what you presented yesterday, because I wanted to highlight that while ROP, we always talk of the retinal pathology, we are not looking at the choroidal pathology in preterm babies, and they have an underlying choroidal pathology, and we don't have the tools to study it. That's why we don't know about it. But it is showing up both in ERG, both in poor visual acuity, even in those patients who never got ROP, and in these, idiosyncratic outcomes. I have another patient similar, which we had triplets, and in triplets, 2 babies laser, 1 anti-VEGF. That anti-VEGF developed complete, detachment just like this. But now I know how to treat it. But now I'm doing a lot of laser and keeping close follow.
I have a question, ma'am. I have a question here. So, like, how about, initially I was thinking that these are choroidal rupture, but in the absence of OCT, can we label it as that it is near the choroid? I saw that probably some of them can be just RP depigmentation without choroidal involvement. What do you think, ma'am?
Yeah, so those lobules are choroidal infarcts. We know that, choroid is lobular, and whenever you see lobular changes, these are choroidal infarcts. But you're right, we don't know at what level it's happening. Just RP rupture, just an ILM rupture, maybe RP choroid rupture, maybe choroidal infarct. So I'm just saying that this whole pathology of the outer retina in ROP has not been studied. We have only studied inner retina, the vessels and the angiogenesis and vasculogenesis. We have not studied the outer retina. So there are outer retinal problems in ROP. I think as we get more tools and as we start looking for these changes, we will learn more.
Yes, thank you.
I only wanted to comment about that hole you said. That is a very typical sign which we have described few years back, which happens also in the CSC cases, the clearing. That is where the point of leak is. In fact, you should describe it and you should report it because it is happening in the ROP after the injection, and you have a very good picture. So we have a very good publication on that, of course, up in the adults, but the clearing is very well described. And that
this
is what
is already published, so we'll see the next case.
No, not that is in the adults in CSC. I'm talking something different altogether, because you have a fluid coming here. Once the fluid comes here, you see, so if somebody is going to see in a baby something like this, one should be very careful. That means it's going to have a exudative. That will be very important, I think.
So next we'll have Dr. Faisal Fayyad. Dr. Faisal is a senior vitreoretinal surgeon.
Hello, everyone. Hi, Susanna. Hi, everyone. Happy to see everyone. I joined a bit late at my office. I'm seeing patients, and this is between patients. It's okay. Happy to be here with you. I'll start sharing my screen. And yeah.
Yes.
Excellent. ROP case video presentation. I'm presenting a couple of cases. One stage 4 and one cicatricial stage 1, stage 5 ROP. This is my first video. This is stage 4 ROP. Here I have to remove the lens because the proliferation is quite anterior, removing the capsule in order to avoid any surprises afterward, like I do in all ROP once I decide to remove the lens, the crystalline lens. And here I'm segmenting the very anterior proliferation with scissor, depressing with one hand and cutting with the other hand the tractional membrane, and I'm helping myself with the cutter as well. This 25 gauge cutter, but this is I can reach more, and I can go in smaller spaces, in smaller places than the cutter itself, because the cutter can be dangerous sometimes. And this is how I do it. And you know, once I depress, I have more space to go inside small spaces with the scissor, and that's why I do it. I'm depressing and cutting with the scissor. Trying to delaminate rather than segmenting, but segmenting also work. But if I can delaminate, I prefer the delamination approach. Here, it's a vascular membrane, as you can see there. It's almost all free. The traction is gone, and this is how it looks like at the end of the case. There is break in flat retina. There was no problem, just some laser and air exchange. This is my first case. This is my second case. This is more complicated case. Here I'm doing temporal approach. Here I injected Avastin a few days before. It was very vascular. After doing lensectomy, I thought that it was much easier to go in temporal approach rather than superior approach in such case. Removing the capsule, and here I have to make space for my scissor and my cutter to go inside the eye, as you can see here with the scissor, and slowly I just do kind of circumcision of this fibrous attachment between this fibrovascular membrane and the nasal retina. There is kind of space there. As I said before, with depression, I can find some space in order to go with my scissor. And this is how I do it. And once I finish that, I go to step 2, which is removing of this thick fibrous. It was fibrovascular, but now it's fibrous. After injecting Avastin by manual approach directly under the microscope. Of course, in such cases, you don't need a lens over the cornea. I'm separating those fibrous membranes from over the retina. And making sure not to make any break, otherwise the game is over. By manual approach, this is the only way that I can remove this thick membrane from over the retina. And you can see it now is completely separated from the surface of the retina. There is some oozing, very mild diathermy, and this is how the retina looks like at the end of the case. Thank you.
Thank you, Dr. Faisal. I just had one question, because I also do this type of cases, and I have a problem that, you know, at the end of surgery, we are not able to laser that avascular retina. Sometimes we have this, because you saw there was a large area which was avascular. And my problem is that after some months and years, they come back with vitreous hemorrhage, new vessels. Because there's so much vitreous adherent to that avascular retina, we are not able to laser that. So that creates a problem.
Yeah, in such cases, really, in case 2, there is no way that I can laser anything. Yeah. In case 1, I thought it was a vascular peripheral retina. I just lasered small, part of the retina where I induced iatrogenic retinal break. but the peripheral retina was vascular. It was quite vascular.
Sometimes I try to do cryo, but still the area of avascularity is too posterior for us to even reach with cryo.
Yeah.
They come back with new vessels, and that's the problem.
I understand, but we do what we can do. I mean, this is just I presented 2 samples of 2 different stages of ROP, but I have no idea if you guys have the same approach or you have different approach to this. I don't know. I'm here to listen and learn from the experts.
Well, those are very difficult cases. Stage 4B and stage 5, surgically, they are very difficult. Sometimes in very bad cases that I can do anything, because even with Avastin, I've got vascularization, it bleeds, and I try to do a two-step approach. So I try to do something in one surgery, then put a little laser, and then put Avastin again, wait until the retina with its plasticity go to its place, then go there a second time and try to complete it. So it's very difficult to say we can do it, we can save the eye, but we try everything. And the two-stage approach, it can work in those very bad cases. But when we are waiting for the second surgery, sometimes you've got phthisis. I mean, it's a complete retinal detachment, but if we do too much in the first surgery, you can make holes. So I try in those very bad cases, make a two-stage approach. But
yeah.
You have the luxury, Suzanne, you have the luxury to do as many surgeries as you wish with your patients. My patients are very much impatient. And I would say over 95% of them, they are referred from outside the country.
Yes, I imagine.
Because in this part, at least where I'm staying geographically, not too many places they do this kind of surgery, and they just come for a few days and they want to leave. I mean, it's a luxury to do 2 surgeries. I'm not sure if 2 surgeries really is better than 1 surgery, because often you have a lot of bleeding after the first surgery. And this is, at least I try to do everything in one shot.
Yes, you are right. You are right. There is no perfect technique for such an ending ROP stage 5.
I really showed Susanna what I do in daily basis.
Those were excellent videos, Dr. Faisal. In fact, we have just run out of time, so I would like to thank each and every one of you, because it was a good opportunity for me to learn. I apologize for my internet connection, but it was really nice hearing all the stalwarts and their surgical skills. Thank you very much. Thanks for participating, and thanks a lot. Thank you, everyone.
Thank you. Thank you.
Thank you, everyone.
See you.
Thank you. Happy to see everyone. Hope to see everyone in real life.
Faisal, you are wonderful.
Oh, thank you. Hope to see everyone in real life soon. Bye-bye.
Sure. So we'll conclude the session. Thank you. Thank you, everyone. Thanks a lot.
Bye-bye.
Bye-bye.
Bye-bye. Bye-bye.